So welcome back. Now today we're talking about another disease that has the word lupus in one of its lab testing, but actually is its very own disease. It's called the Antiphospholipid antibody syndrome, or APLS for short, and is sometimes just referred to as the antiphospholipid syndrome, or APS. It was discovered in the 1980s by rheumatologist Dr. Graham Hughes, and it is a type of autoimmune disease where the immune system becomes overactive and starts attacking something that's a balance on the inside of our body that is naturally there. It's a balance that keeps our blood thick or the right thickness in certain parts of the body. So, for instance, if a patient gets a paper cut, it'll cause the blood to clot and not have the patient bleed to death. However, that same blood is kept thin as it flows through the heart and through the lungs. It's a very rare disease, meaning that you would need about 15,000 people in a room for even one person to get it. And it is one of those diseases, though, however, that has the rule of 1 in 5, meaning that 1 in 5 people who have had a stroke below the age of 50, strokes in young folks, actually have this disease that's causing it. 1 in 5 people who have had multiple miscarriages can have this disease as causing it. And 1 in 5 people who have had blood clot for no reason can have this disease as the cause of it. The risk factors for this disease is it can run in families. It can be genetics. It's more often in women. It's more often in women that are the ages of 30s to 40s, and it can be more often in certain groups such as Blacks, Hispanics, Asians, and Native Americans. The symptoms of this disease are basically blood clots in the arteries or in the veins throughout the body. So it can cause clots in, let's say, the legs or the lungs or the heart or the brain. It can cause multiple miscarriages in younger women. It can cause kidney problems. It can cause skin problems. It can even cause some blood count problems. It can cause heart valve problems, and it can give more atherosclerotic disease. The way to diagnose this disease is a little bit tricky because remember, it's something that is a natural system. We have it there all the time. So you have to have a patient who has had either a blood clot or has had multiple miscarriages and then has had some of these labs positive. So for instance, though, if you have a patient that is on their way to the lab to get their blood drawn and they even stub their toe or they have a small fall, suddenly their clotting factors are activated, and when they go to get this blood work done, it'll show that they have a clotting problem when they really don't, which is why you need to repeat it in about 12 weeks. And about a fourth of these patients have what's called a false positive lab test, meaning that the lab test is there, it's abnormal, but it's not causing disease, such as in those patients who are pregnant, who are on certain medications, and have certain infections. And then once the diagnosis is made, then this disease is divided into primary or secondary causes. Primary meaning it's its very own disease on its own, nothing is causing it or nothing is irritating it. And secondary meaning that there is something else that's chronically irritating the immune system, and the immune system now then creates this disease, such as in autoimmune diseases like lupus, but certain medications, infections, and certain cancers. To make it even more fun, there's a lab test called the lupus anticoagulant. Even though this disease is not lupus, and even though this disease does not thin out the blood, it actually makes the blood more thick. The treatment for this disease is what I call the back end approach, because you really can't push the immune system down enough to make this disease go away, but you can prevent blood clots in patients by thinning out their blood when they need it or thinning out their blood for a little bit longer. As far as the prognosis of this disease, it really depends on the type of blood clot the patient has and the types of labs that are there. So for instance, if a patient has had some labs that are off, and maybe they've had multiple miscarriages, they don't need a blood thinner all the time, but when they get pregnant, they may need a blood thinner to help that pregnancy go through. Compare that to a patient who has had a major blood clot, such as a stroke or a heart attack or a lung stuff. They may need a blood thinner for a little bit longer. Also, these patients can get more atherosclerotic disease because if you imagine the pipes of blood going to the heart and to the brain, they can get narrow and more narrow as they get blocked up with stuff. And also these patients can get more heart valve disease. And in this case, I think in this disease anyway, it's very important for patients to understand that every medication has a risk. There is a big difference between a body that has disease and a body that doesn't. A body that has more disease and a body that has less. So some of these medications, even though some of these blood thinners, they may be scary, they may be life-saving in those patients that have the disease. And take it from someone who's had a stroke, certain medication risks are worth it. Until next time.